Now it's time to learn about the latest immunotherapy progress in treating lung cancer, a cancer that kills more people worldwide than any type of cancer. Joining us is expert immunotherapy oncologist, Dr. Julie Brahmer, who is co-director of the Upper Aerodigestive Department and the Bloomberg Kimmel Institute for Cancer Immunotherapy at the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center in Baltimore. Brian Brewer from the Cancer Research Institute will be sharing your questions with Dr. Brahmer, so please be sure to put them in the Q&A box. Dr. Brahmer, Brian, let's talk about lung cancer immunotherapy.
Hello, I want to thank CRI for allowing me to come to speak with you today about immunotherapy for thoracic malignancies. It's a great honor, and I want to welcome everyone to this session. So for thoracic malignancies, over several decades, chemotherapy was the cornerstone of treatment. Multiple combinations for thoracic malignancies worked very similarly, and they had a small benefit for patients, but yet it was real. The problem is with chemotherapy, the response or control of the cancer just tends not to last as long as we would hope. However, the response does tend to be short-term and does improve quality of life and does improve how patients do. However, of course, we want to improve how things work for patients with thoracic malignancies. However, in 2014, we started to see benefits in patients with non-small cell as well as small cell lung cancer with something called PD-1 therapy. PD-1 therapy is an antibody that's given by vein, and the goal of this is to try to get your own immune system to attack the cancer. One evaluation that we saw was that if a patient's cancer expressed PD-L1, which is what we call the ligand, what PD-1 targets, if it expresses it, then we think that that's a predictor of response, particularly for those patients with non-small cell lung cancer. For patients with small cell or mesothelioma, PD-L1 tends not to be a great predictor for response to treatment. So PD-1 therapies, by blocking that binding of PD-1 on a T cell to PD-L1 on the tumor cell, does allow your immune system to be able to recognize the cancer and actually control it or make it completely go away. Initially, again, in 2014, we saw activity, and then finally, PD-L1 antibodies were approved for treatment for non-small cell lung cancer in the advanced stage or stage 4 disease after chemotherapy. Pembrolizumab was then moved up into the first-line treatment. This is a PD-1 antibody. It was moved up into the first-line treatment or the first treatment for patients with advanced disease if the patient cancer had high PD-L1 expression. PD-L1 expression can be seen on some cancers. Sometimes it is seen at low levels. High levels, we say, is basically if 50% or greater of the cells underneath the microscope stain for this antibody, the PD-L1. Some patients' tumors do not express any PD-L1, so we call that PD-L1 negative. About 30% of patients with metastatic non-small cell lung cancer have high PD-L1 expression on their cancer. About 30% of patients, their cancers have expression that range between 1% of cells to 49% of cells. And then about a third of patients have no PD-L1 expression on their cancers. Then as time has gone on, more therapies are approved for use in non-small cell as well as small cell lung cancer. And we're moving immunotherapy from advanced stage disease all the way to early stage disease. By combining PD-1 therapy with chemotherapy in patients with advanced non-small cell lung cancer, we saw these patients also could live longer regardless of the PD-L1 expression. So while pembrolizumab was approved for use for PD-L1 high disease in the advanced stage setting, PD-L1 such as pembrolizumab can have a response rate or decrease in the cancer rate. About 40% of patients can have decrease in the size of their tumors if their cancer is PD-L1 high. That response can be maintained for a very long time and also even improve survival even beyond 5 years. But now with pembrolizumab only being used by itself in patients with high PD-L1, the thought was, well, what can we do for other patients as well? And so PD-1 therapy was combined with chemotherapy. It can work in and add to the response in PD-L1 high, PD-L1 1 to 49% cancers, as well as PD-L1 0%. So regardless of PD-L1, combining chemotherapy with immunotherapy improves the response rate, so shrinkage of your cancer, as well as does improve how patients do long term. Particularly, we use PD-1 therapy with chemotherapy in patients with PD-L1 low or 0%. So really, by 2017, PD-1 inhibitors really have become the cornerstone of therapy for patients with metastatic non-small cell lung cancer. We also saw for patients with small cell lung cancer, combining immunotherapy with chemotherapy also improved how those patients did if they had metastatic disease. So then in 2018, there was data that came up from in those patients with earlier stage non-small cell lung cancer, and that is stage 3B or unresectable stage 3A. In that stage, the standard treatment was really chemotherapy and radiation therapy, and no other therapies really showed improvement in how patients did long term. But durvalumab was looked at in this setting to be given after chemotherapy and radiation. And it was noted after a year of durvalumab, more patients lived beyond 5 years compared to those patients who didn't receive durvalumab after chemotherapy and radiation therapy. And so now that is standard of care for those patients with that earlier stage disease, but unable to undergo surgery in that setting. So also, what about chemotherapy or immunotherapy combinations? So various different immunotherapy combinations have been looked at. So using a PD-1 antibody plus another antibody to try to increase the chance that your immune system can recognize your cancer. This therapy, this combination therapy that is now approved for use is called ipilimumab, which is a CTLA-4 antibody that blocks a pathway called CTLA-4, which is important to help your immune system to be able to recognize the cancer. By blocking this, again, it's another way to get your immune system to recognize the cancer. It was ipilimumab, now also known as Yervoy, was combined with Opdivo or nivolumab. That is a PD-1 antibody. So the thought is these antibodies together could work better than just the one antibody. And it did show an advantage of doing two antibodies together compared to chemotherapy for patients with PD-L1 positive non-small cell lung cancer. We've also looked at combining chemotherapy with that combination of CTLA-4 plus PD-1 or Yervoy and Opdivo, and that too also improves how patients do with metastatic non-small cell lung cancer. Now, the Opdivo and the Yervoy was also looked at in a completely different cancer, but is under the umbrella of thoracic malignancies or cancers that can occur in your chest, and that's called pleural mesothelioma. Mesothelioma is a cancer of the lining of your chest called the pleura, and mesothelioma tends to be associated with asbestos exposure. Prior to all this information, the mainstay of treatment was chemotherapy that, again, it worked okay. It did help control the cancer, but not for very long. Some patients with mesothelioma didn't respond at all to chemotherapy. And so Opdivo and Yervoy, again, the CTLA-4 antibody plus PD-1 antibody, did show response. And that response, if patients' cancers were controlled, lasted a very long time. And we can even see long-term control in these patients, where in the past, long-term control was not even talked about. So ipilimumab and nivolumab are approved for use in patients with mesothelioma, as well as in non-small cell lung cancer. So then in 2020, the thought was, can we move these therapies into very early stage and help cure patients with early stage non-small cell lung cancer? And there have been various different studies either giving chemotherapy and immunotherapy before surgery in patients with early stage non-small cell lung cancer, or should we just give it after surgery by itself? We've also looked at different types of immunotherapies, trying to increase the chance of someone with lung cancer to be cured of their disease. And thus far, several of these therapies have not helped adding it to PD-1, but more different types of immunotherapies are being evaluated. So today, immunotherapy is the foundation of treatment for non-small cell lung cancer throughout the continuum of stages. In the advanced stage setting, pembrolizumab is approved for use by itself in patients with high PD-L1. It is also approved for use with chemotherapy in advanced stage non-small cell lung cancer, regardless of PD-L1 status. We also have other very similar immunotherapies approved for use in the first-line treatment setting that are also in this family, such as atezolizumab as well as cemiplimab. We also have combination immunotherapies in advanced stage non-small cell lung cancer, the Yervoy and Opdivo combination, or combining that combination with chemotherapy. For small cell lung cancer, we also have in the advanced stage setting therapies such as durvalumab or atezolizumab combined with chemotherapy in the advanced stage small cell lung cancer. For advanced stage mesothelioma, we have ipilimumab or Yervoy plus nivolumab Opdivo approved for use in patients with advanced stage pleural mesothelioma. Now, for early stage disease, non-small cell lung cancer is the only thoracic malignancy that has immunotherapy approved for use. In patients with unresectable non-small cell lung cancer, we have, after chemotherapy and radiation, durvalumab approved for use, and that is given over about a year, and then it's stopped, and patients can do well long term. In the early stage setting, so if you are felt to have cancer that can be removed by surgery, We have either chemotherapy and Opdivo approved for use before surgery, or we have a drug called atezolizumab given after surgery if you have PD-L1 positive non-small cell lung cancer. Depending on the stage and depending on the chance of surgery, depends on whether or not we decide to give it before surgery, or if you've already gone to surgery, we give it after surgery. So new therapies will continue to build on these successes. Obviously, we still have a lot of work to do in these settings. We can certainly improve therapy. And so people are looking at combining different antibodies. We're also looking to combine it even in early stage disease in small cell lung cancer, as well as mesothelioma. We also are looking at using what we call engineered T cells, or you may read about CAR T cells in some of these settings as well, where T cells are removed from your body and then engineered and then put back in, either by itself or in combination with these immunotherapies. But the T cell therapy is still very experimental. New approaches may utilize, again, like I said, combinations of immunotherapy with other therapies or entirely new ways of boosting our immune system to beat back cancer. I want to thank you for joining me today, and now we'll take questions.
Dr. Brahmer, thank you so much for that talk on immunotherapy for lung and other cancers of thoracic cancers, including mesothelioma and the various types of lung cancer and subtypes. Very exciting to see so much progress there in lung cancer. Of course, lung cancer, one of the first cancers to show success in immunotherapy, I believe, after melanoma. So there's been a lot of development there in the last 8 years or so. So let me just jump right into questions. We don't have much time. So these are questions. Some have been submitted at registration by those watching. And for those of you watching live now, feel free to submit your questions in the Q&A box, and we'll try to get to as many as possible. So Dr. Brahmer, toward the end and at various points in your talk, you referenced a lot of the PD-1, PD-L1, anti-CTLA-4, and it seems like those dominate the treatments that are currently available. But then you reference, or you mentioned at the end, new treatments, other new treatments. What other targets are there? Why are scientists looking at those targets? And are those involved in clinical trials that patients might be interested in?
Yes, so there's various different checkpoints that our immune system uses as kind of a checks and balances. Some of the checkpoints turn on the immune system, other checkpoints turn off the immune system. So either by helping them turn on or blocking some of these pathways, it can help rev up the immune system and help direct it towards your cancer. And there's various different pathways. And so we're trying to figure out how important are either certain ones. Right now, PD-1 pathway seems to be one of the most important in non-small cell lung cancer. But obviously, for a lot of patients, their cancers may co-opt others. And so they're looking at TIGIT pathways, TIM3, as well as other pathways, VISTA, you name it. There's multiple different pathways. This is kind of a tangled web of pathways that your body is trying to use to either turn on or turn off your immune system. And cancer can co-opt and use that in very similar ways, but use it to save itself. And so we're trying to find ways to change that. Now, there are some patients who just have what we call cold cancers, so immunologic cold, where it uses various different mechanisms to keep the immune system out. Either the cancer does not express the machinery for your immune system to recognize it, or it does a great job of keeping the immune system out using other pathways. And so again, we're looking at combining things together. And this kind of leads to precision immunotherapy. You might have heard about precision medicine, where that we're looking at genes to try to target and use various different drugs to target those abnormal genes. Now we're trying to look at precision immunotherapy to try to use what is in the cancer, how well your immune system works, or even your gut bacteria, to see if we can change these different things to help increase the chance that your immune system can recognize your cancer.
Well, on that note, one of the questions we have is, how important is genomic sequencing and using that information to guide treatment? Do I need to ask my doctor to run these tests, or are they standard?
For non-small cell lung cancer, it is standard, particularly for patients with advanced stage disease. However, it is also important to know this in earlier stage disease. And so it's something to always ask your doctor. Genomic sequencing is important, particularly for those patients who are never smokers or light smokers. They tend to have cancers that are driven by one or two genomic changes. And these cancers tend not to respond to drugs like PD-1 or PD-L1 antibodies, or even the CTLA4 antibodies. And so we usually go first with those targeted therapies before we start using chemotherapy plus immunotherapy in that setting. So it's very important to know that, because the drugs that are developed for those specific genetic changes work much better than immunotherapy. And so it's important to ask your doctor. Now, most of the time, doctors are looking at this, but it's also important to ask what was all checked. Were mutations checked, or something we call fusions checked? You want all of that checked. And mutations are just changes in the gene. Fusion changes are where the genes abnormally fuse together and turn on when they shouldn't be. And those also can be targeted with pills or different antibodies that are directed to those changes. So it's important to know that, because again, immunotherapy tends not to work well in those type of cancers compared to patients that have multiple different genes that we just can't target, where immunotherapy can work.
I see. If a patient is not responding to PD-1 immunotherapy, it sounds like these other targets might be, and other combinations might be, an option. Is that something a patient discusses with their doctor? Does the doctor bring this up? How much does a patient have to advocate for his or herself?
Well, I think as a patient or a patient's family, to be able to learn at least some of the basics about lung cancer and know what questions to ask is extremely helpful. Because this is being used in the community so much, physicians will know what to do next. But for looking for experts that all we do is take care of patients with your particular type of cancer is an advantage. But again, not everyone is close to a large center where the doctors can specialize in one type of cancer. And so a lot of times patients will come to us to ask advice, either virtually or in person, and that can help as well, or their physicians can reach out as well. Plus, we do have guidelines. One guideline that we use is called the NCCN guidelines, and patients also have access to these guidelines that help you through your journey with your lung cancer or mesothelioma. I do think for most patients, after the first type of treatment, the immunotherapy by itself or immunotherapy in combination with chemotherapy or other immunotherapies, the next type of treatment, we don't yet have a drug or combination outside of just chemotherapy combinations approved by the FDA. So talking with your physician about clinical trials that are looking at getting at the question of what is causing the resistance in the in your cancer, and how is it getting around your immune system? So it's important to ask about that and whether or not you would be right for one of those clinical trials, because we don't yet have a drug approved for use in the immunotherapy space if immunotherapy doesn't work at the beginning.
Good to know. Good to know. And good to know that patients should make those or have those conversations. And as you said, equip themselves with this information so that they know the question to ask. And we'll look into that NCCN guideline and share that potentially as a resource on our website for folks who are interested.
Yeah. There's other.
Sorry, go ahead.
Sorry, I was going to say there are other guidelines as well. Different professional societies also put out guidelines for the various different types of lung cancer, as well as mesothelioma. Something called ESMO, as well as ASCO, have guidelines, but these are a lot wordier. So if you're very interested in reading about how the guidelines were put together and why the decisions were made, the NCCN guidelines are just, in my mind, a bit easier to follow because it almost is laid out like a roadmap. Also, the American Cancer Society has something like that as well.
Wonderful. Thank you. Another question from one of our registrants, and this goes to, again, other types of combinations. During yesterday's basic immunology session, we learned about something called CAR T cells. Are these being used in lung cancer? My impression was they weren't working very well in solid tumors.
So right now, engineered T cells or CAR T cells have not been approved for use for any thoracic malignancy. They are being tested in these settings. Like the question noted, that thus far they haven't worked well, but I think we're just hitting the tip of the iceberg. While these type of therapies are approved for use for patients with leukemia, as well as other malignancies such as multiple myeloma, we haven't yet figured out how best to use them in patients with thoracic malignancies or other solid tumors. But some of that is trying to find the right target to engineer the T cell to be directed towards. Folks are working on that, as well as also how do we get those T cells to hang around in your body for a longer period of time so that they can work. And so various different things are being looked at in that setting as well. If you are interested in this, again, ask your physician to direct you towards a center that specializes in this type of therapy and clinical trials for patients with solid tumors such as lung cancer or mesothelioma.
You bring up a nice segue to another question we received. How long does immunotherapy stay active in the body?
So we can detect immunotherapy, these type of antibodies, for even at least 3 months after your last dose. And however, we can detect the effects of that antibody on your immune system for years. So it's something to remember, like if you have to stop treatment because of side effects or stop treatment because your treatment has been finished, those immune effects can last for a very long time. So if you have symptoms that occur, you also always have to keep in the back of your mind, is this due to your immune system being too active, or is it just something else that's run-of-the-mill general medicine problem?
Okay, great. Keep those questions coming, everyone. If we don't get to them all, we'll try to do some follow-up after the event, so you can look to the cancerresearch.org blog for that. 2 questions about someone's health status when considering immunotherapy. I guess this would be a trial, maybe not part of the standard of care. I'd like to consider a clinical trial. Is age a consideration, and the fact that I have an autoimmune disease?
Yeah, so age is always a consideration. However, I would say age is only relative. If you are older, but you're extremely active and otherwise healthy, it really doesn't play much of a factor, though we have to watch various different side effects, particularly from chemotherapy, such as side effects on your kidneys, which just As you age, kidneys are just more sensitive. For patients with autoimmune diseases, that's a different setting. So if you have an autoimmune disease, it's not an absolute contraindication to being placed on immunotherapy. However, we have to counsel you about the fact that your autoimmune disease can flare when we put you on this type of therapy. If you're on medication for that autoimmune disease, that too may also affect whether or not your immune system can actually respond to the cancer and the treatment that we're trying to give you in order to stimulate your immune system. So it's kind of a double-edged sword.
Well, thanks. That's all the time we have, Dr. Brahmer. This is very fascinating, very hopeful. Before we conclude, is there anything you'd like to say, any advice to give patients and caregivers who are encountering a lung cancer diagnosis for the first time and maybe learning about immunotherapy for the first time?
Certainly, I want to tell patients there's hope. Even when you are diagnosed with metastatic disease, there is still hope for long-term control and potentially even cure in some situations. Now, in early stage disease, we now have immunotherapy as well. So it's very important to ask, is immunotherapy right for me, regardless of the stage and type of cancer that I have?
Well, thank you for that. That's excellent advice. Once again, Dr. Brahmer, Dr. Julie Brahmer, thank you for joining us. And for those of you watching, we encourage you to stay for our next breakout session coming in just a few moments. Thank you all. Thank you, Dr. Brahmer.
Thank you.